Okay, just my disclosures. The lawyers always ask that I do this. I point your attention to the bottom line, which is the most important one. Okay, so the big question is, are there unique toxicities with these checkpoint inhibitor therapies? And the answer is yes. We call them immune-related adverse events, and they can affect virtually any organ system in the body. I used to tell patients, well, immune-related adverse events can occur to any organ, perhaps except the heart, but then you perhaps have heard recently that there are multiple reports of myocarditis. So the answer is, now I tell them, it can affect any part of the body. And what are these? These are either general events, typically fatigue, pyrexia, chills, swelling of lymph nodes, which can be very difficult to interpret, rare infusion reactions, but then we have these organ-specific autoinflammatory events, and almost all of them get better with steroids. But again, there's this balance of these immune-related adverse events versus self-tolerance. And it is extremely important to know how to manage these events when you're using these drugs. This is a stylized figure of the kinetics by which they occur. Usually the rash occurs first, followed by diarrhea or GI toxicity, then endocrine, liver, and lung toxicities. And again, the key to understanding and treating these complications is early recognition and expectation. You need a cadre of consultants in the specialties to be able to manage them. And again, for most histologies, there's really very little evidence that the type of adverse event varies, although in melanoma we do see vitiligo, which is generally not seen in most other cancers, and pneumonitis, as you would expect in lung cancer, is more of an issue. Again, this is a non-stylized, very exact indication of the kinetics in melanoma of the onset of these immune-related adverse events with nivolumab. Nivolumab, by the way, pembrolizumab, these are very similar drugs, and the adverse event profiles of these drugs are very similar. And again, you can see the vast majority of the events are skin, because the area under the curve in this graph relates to the likelihood of these events occurring. So you see skin first, followed by GI, followed by hepatic, and then late you see the endocrine toxicities. And the endocrine area under the curve is pretty high because we see a fair number of endocrinopathies. And the more you look for, the more you will see, as you would expect. And again, if you look at the combination of ipilimumab and nivolumab, which again in GI cancer is not used very much at all, although it could be used in the future, things are a little different. The adverse events occur earlier and last longer. So if you look at the orange curve for each of the different types of toxicities, the orange line is occurring earlier and it's probably lasting longer than the blue curve, which is nivolumab alone. And again, if you grade them by the classic system of 1, 2, 3, 4, most of the time grade 1 toxicities elicits no specific action other than being a little extra vigilant. Grade 2 toxicity, we used to think, well, we don't need steroids, but I will often use a short course of steroids for grade 2 toxicities. You might delay a dose, hold a dose, so you have to be very careful with grade 2 toxicities. Grade 3 almost requires always systemic steroids, and you'll either withhold the dose to be continued upon quick recovery, or you might even discontinue the therapy. Grade 4 toxicities, you almost always will discontinue therapy. And again, if you have an endocrine-mediated adverse event, as we say to the patients, once you toast the pituitary, it's gone. So you may give replacement hormones, and in some cases, you actually could continue. Again, risk factors. The obvious risk factors are people who have a prior history of autoimmune disease. Obviously, in the rare case that you're actually treating someone with an active autoimmune disease, which again doesn't happen often but can happen, those of course are the patients at greatest risk. And again, if you had prior checkpoint inhibition, let's say you had ipilimumab and you had an immune-related adverse event, then yes, upon subsequent treatment with another checkpoint inhibitor, you will have an increased risk of developing an immune-related adverse event. And if you start with IPI and move to Nivo, you have a higher chance than if you start with Nivo or Pembro and then move to ipilimumab or a similar drug. There are many questions that I'm always asked, and the question is, at what point and for how long should you treat with steroids? When should you use infliximab or a mycophenolic acid? And we'll get to that in a little bit. Can you take a patient who had a previous grade 3 or 4 immune-related adverse event and retreat them? And the answer is, if you use good judgment and if there's complete resolution of the event, and if enough time has elapsed, yes, you can do that. And what are the patients for which there's an absolute contraindication to using a checkpoint inhibitor? And the answer is generally an allograft recipient. But even in the allograft patients, you can use ipilimumab and actually get away with it. But using pembrolizumab or nivolumab or a PD-1, PD-L1 drug in a patient with an allograft, kidney, heart, lungs, etc., I think is fraught with hazard, and they will be rejected. And it's a little different treating someone with a kidney transplant. If that gets rejected, you can go on dialysis. If you reject a liver transplant, you're dead. So it's really a place for a judgment call. Let's just quickly go through the most common, or in fact, the adverse events. Skin, most common, classic maculopapular eruption, especially on sun-exposed areas, and it's a deep dermal infiltrative immune cells, and often you see itching with no rash. You might see rash, and almost always you'll see some itching, but you can actually see itching with no rash. And again, this has been studied. This is an article that's recently been published in the Journal of Clinical Oncology. Interestingly, this is a pretty large compendium of skin toxicities. 1/5 of the patients actually required systemic steroids. Usually these are managed with antihistamines, topical steroids, moisturizing lotions. It's a little unusual to have to treat someone with systemic steroids. And interestingly, in this study, for the first time, some of the etiology was explored because serum IL-6 levels were elevated, IL-10 levels were elevated, eosinophils, antibodies. So now we're beginning to understand really for the first time what could be associated, what markers could be associated with the onset of these toxicities. Diarrhea is the sort of thing that concerns us a lot, and colitis, of course. It is one of the most common immune-related adverse events. It is more common with ipilimumab or combination therapy than it is with nivolumab, pembrolizumab, or any of the PD-1, PD-L1 antibodies. If you do a colonoscopy or sigmoidoscopy, you see this diffusely erythematous, often ulcerated friable mucosa. There's again a deep infiltrate of CD4 and CD8 T cells. You see cryptitis. It is a classic appearance that actually looks just like Crohn's colitis or ulcerative colitis. And almost everyone responds to long courses of steroids, but if patients don't respond within 72 hours to steroids, they must be given infliximab or Remicade or a similar biologic drug. And you want to avoid this dragging on because this could lead in rare cases to perforation, toxic megacolon, and a profound ileus. Hepatitis, very common, especially with combination therapy. You must check liver functions before each dose. I have seen one patient die because, thank God, not in my institution, but in another institution, an investigator failed to check the liver functions before treating a patient with pembrolizumab. And they had elevated liver functions, no symptoms, they felt fine, and they eventually died of liver failure. Check the liver functions. And again, you may find elevated liver functions with no symptoms at all. Or, as I saw a patient 2 days ago when I was in clinic just before coming here, a patient with AST/ALT in the 800 range who had fatigue, feverishness, and just felt terrible. And again, the liver function abnormalities can drag on and on and on in spite of use of steroids. And again, if you have AST/ALT less than 2.5, it's okay to treat. More than 2 or 2.5, I will usually skip a dose, hesitate, delay. I might even give a Medrol dose pack, which is the 6-day scheduled regimen of oral steroids. And then if the LFTs resolve, treat the patient. But that is the sort of thing that comes with experience. Again, grade 3-4 toxicity is liver functions above 5 times the upper limit of normal or bilirubin above 3 times. You have to monitor these patients carefully. I check them every other day for their liver functions. And again, they almost always get high-dose steroids, excuse me, I will give them a methylprednisolone injection, 125 milligrams, in the infusion center, and then they go on steroids for at least 30 days, sometimes as much as 45 or 60 days. If they improve quickly, I can bring the steroid taper to a close more quickly, but if they don't get better within 72 hours, they need to be given another drug, and that usually means mycophenolic acid at 1 gram orally twice a day. And if the patients are not getting better, if you're giving second and third drugs, they need to see the hepatologist. The endocrine immune-related adverse events are shockingly common. If the symptoms are moderately severe, for example, a severe headache, hold the drug. And if they have a severe headache, they get intravenous methylprednisolone. Otherwise, they get a relatively brief steroid taper, because to tell you the truth, there's little evidence that giving a steroid taper improves the symptoms of an endocrinopathy other than getting a headache. And of course, you replace the hormones. You have to check cortisol, ACTH, thyroid, TSH, and in a man, testosterone. And again, remember to replace the hydrocortisone before the thyroid. And again, when I first started doing this, this was 2001, and I had forgotten everything I ever learned about endocrinology. I had to relearn it all, and the endocrinologist reminded me that you can provoke a crisis, an Addisonian crisis, by giving a patient with hypopituitarism, with low ACTH and low TSH, by giving them a dose of Synthroid at the same time that you give them hydrocortisone. So you give them the hydrocortisone first. It doesn't need to be a week. It could be a few days. First give them the hydrocortisone if they have panhypopituitarism, then replace the thyroid hormones. And it is rare, but you can see some replacement of your thyroid function and your cortisol function, but most patients with hypopituitarism are done. They will be on lifelong hormone replacement, and you have to make that clear to them that that is a risk, and that is something I always discuss with the patients. And finally, if they go on hydrocortisone, you have to remember they have to have the little bracelet, the medical alert bracelet, that they're on replacement steroids, and they need stress steroids if they have surgery or some other emergency or trauma, and you need to remember that. And this is what you see if you have that worst headache of your life. The normal pituitary is about 8 millimeters. If it goes to 11 or 12 millimeters, you can have the worst headache of your life. And you see this inhomogeneous pituitary. This is classic. This is a 14-year-old publication, but it looks the same today as it did then. And the findings are not very impressive, but I've seen some unbelievable headaches with just a slightly swollen pituitary. And again, it is extremely common to see endocrinopathies. In this series, it was 18% of all patients, and the problem is we're always looking for it. In most of the trials you've done with drugs like pembrolizumab or nivolumab, usually you'll be checking T4 and or TSH with each dose. So the more you look, the more you're going to see. If you give combination immunotherapy with ipilimumab and or pembrolizumab or nivolumab, you're going to see more. And again, it takes some time to see these endocrinopathies occur. The median is 8 to 10 weeks. And again, the majority are identified in patients with very subtle symptoms, a little fatigue. And again, of course, they have cancer. Of course, they're going to be fatigued. So it can be very difficult to discern the symptoms and to distinguish that from either the underlying disease or the side effects of other therapies. And again, one thing that I always tell patients is there is a rare but finite chance of developing inflammation of the islets. And once the islets of Langerhans are inflamed, as I say, they're toasted, they are gone, and you can develop diabetes mellitus, type 1, insulin-dependent diabetes, well less than 1% of the time. It's about 0.2% with nivolumab or pembrolizumab, but it is a real phenomenon and the patients need to know about it. It can happen just like that. You can go from a glucose of 100 to a glucose of 800 in a week after getting a treatment with PD-1 antibodies. And again, you have to monitor the glucose continuously. Sometimes you'll see it creep upward, and that's a hint that you're developing glucose intolerance, I'd be very cautious continuing to treat those patients. And the few times I have seen this, I've perhaps seen 3 patients out of 1,200 that I've treated with type 1 diabetes. They are dependent lifelong on insulin, so make sure they give proper informed consent. And again, there's no evidence that giving steroids would do any good. Obviously, the steroids might make the glucose worse. And amazingly, once you develop diabetes, you actually can continue checkpoint inhibitors, and I've done this, especially in a patient who seems to be benefiting. Pneumonitis is a big deal in lung cancer. It's probably less of a deal in GI cancer or in melanoma. It is not common, but we routinely check the pulse oximetry in all our patients. If there's any issue with shortness of breath, low pulse oximetry, we check a chest x-ray. If there's any issue with the x-ray, we get a CT of the chest that day. Because if patients develop pneumonitis that's symptomatic, you need to move quickly. They will get a high-dose steroid taper. Usually it's about 2 milligrams per kilogram. It's generally at least over 45 days. And remember, the CT findings, just like you were taught in medical school, will lag behind the clinical findings. The patients will feel fine. They'll go out and play golf a month and a half after pneumonitis, but if you look at their chest CT, it shows these fluffy, indistinct infiltrates, no questions. And again, you can see a waxing and waning course, and you may have to retaper the steroids. And if you don't see a response within 72 hours, just like in colitis, you need to give a dose of infliximab or Remicade. Neurologic irAEs are also infrequent, but they can span the spectrum. I've seen everything. I've seen mononeuropathies. I've seen Guillain-Barré. I've seen myasthenia gravis. And the particularly troubling thing is either encephalitis or aseptic meningitis. The patient will show up with a horrendous headache, and you'll immediately get an MRI of the head if they show up in the emergency room and there are no findings. So they obviously don't have tumor causing the headache. And in GI cancer, brain metastases are maybe a little less common than with melanoma or lung cancer. But you're probably going to need to do a lumbar puncture if someone presents with a really, really bad headache, because they'll either have aseptic meningitis or encephalitis, and they're going to need high-dose steroids, and you're going to have to discontinue your checkpoint inhibition. That being said, I've treated several patients who had aseptic meningitis, complete recovery. They get better very quickly with steroids, and then I've continued their treatment over months, and they have not had any return of the aseptic meningitis. So this is one of those scenarios where you can potentially continue the treatment. Cardiac toxicity is a relatively recently discovered issue. It was first described in 2016, if you remember, in the New England Journal in an article by Doug Johnson from Vanderbilt. You can see pericarditis, you can see myocarditis, you can see arrhythmias, and again, the incidence of cardiac issues is much higher with combination therapy. Thank God it is relatively rare. I probably have never seen a bona fide case of myocarditis with congestive heart failure, and I've treated easily 1,200 patients with checkpoint inhibitors. But again, this is a scenario where you really need to jump on it. You need to give high-dose steroids, 2 milligrams per kilogram. They get intravenous steroids in the beginning. They generally will get hospitalized if they have symptoms of congestive heart failure. And you need to escalate quickly within 72 to 96 hours to infliximab, mycophenolic acid, and if they don't work, anti-thymocyte globulin. And this is where you get that cardiology consult, just like that. So this is a big deal, and again, the good news is it's pretty rare. Rheumatic immune-related adverse events, in contrast, are relatively common, especially arthritis in weight-bearing joints. If you give prolonged PD-1 antibodies over a year, say, so again, it's usually PD-1, it's not CTLA-4 blockade, and again, these are generally treated symptomatically, although I have had occasional patients who had such bad arthritis of the hands, hips, and knees that they could no longer write. And this was a patient who had to write for a living. I stopped the therapy. I actually gave them a short course of systemic steroids, and they recovered perhaps 90% of their function. But again, this is where the rheumatologist can actually intervene and may actually be of use to you. The other immune-related adverse events, pancreatitis, is actually not uncommon. And when we see nausea and abdominal discomfort, we will check an amylase and a lipase. We've seen uveitis, which usually goes, as many of you in the audience know, with GI toxicities. And nephritis, I've seen maybe 2 cases out of 1,000. That's very rare. And they usually get better very quickly with steroids. Again, the kinetics of resolution vary. With the skin, when you treat them, they get better very quickly. They happen early. GI happens early and will generally get better quickly. Pulmonary complications near the bottom happen at any time and can take a long time to recover, which is why you give 45 to 60 days of steroids to those with grade 3 pneumonitis. A big question I'm always asked is, are the immune-related adverse events associated with outcome? And my personal opinion is very weakly so, because the patients will ask you, oh my God, I'm not getting any toxicity. Does that mean the treatment isn't working? And I always tell them, no. There are plenty of patients with no toxicity who do well. There are plenty of patients who get toxicity who do very poorly. But again, this has been studied in detail, and I'll just give you some quick snapshots. And again, this was one study at MD Anderson, one institution, a very large institution, and they went over something like 98 patients with various types of cancers who got checkpoint inhibition. And again, they found that if you look at the bottom, when you had grade 3 or 4 immune-related adverse events, they found that in those who had the toxicity, there was an elevated response rate, progression-free survival was increased, but the survival was not significantly changed in those with the immune-related adverse events compared to those who did not. Here was another study that was done in Europe, a large number of patients, 389 patients, and again, in this scenario, they called them DRAEs, drug-related adverse events. Again, in this scenario, they actually found that there was a survival benefit to those who had these immune-related, drug-related adverse events. And again, this was both a univariate and a multivariate analysis. So in this case, you have a large number of patients. It does appear as if there's an association of outcome with survival. Many of these patients had lung cancer. And again, this was a larger compendium of just lung cancer patients. And again, this was mostly done in Europe, but I think some of the patients came from the US. And they had a significant number of patients who had any grade immune-related adverse events. And they did a very careful analysis. They looked at all immune-related adverse events. They did it by grade. They did it by type of immune-related adverse event. And if you look at the bottom 3 bullet points, response rate, PFS, and OS were associated with any grade immune-related adverse events. And in this scenario, you have to adjust for what is called the time delay bias. And any of you who have heard Lex Egermont from Gustave Roussy talk about this, Lex has this idea that you have to worry about the time delay bias, and he's absolutely correct. Because the more you treat the patients, the more likely they're going to have the immune-related adverse events, but the more likely that they responded and will get benefit. So in this scenario, they did a landmark analysis, and in spite of the landmark analysis, there was an association. And lastly, this was a huge number of patients, and this time it's urothelial cancers. And again, if you look at response, there was an association. The survival association was pretty weak. And if you add all the data together, lung cancer, melanoma, and I'm sure for GI cancer, there is a weak association of response and PFS with outcome. The survival association, to me, is unclear, and any analysis has to take into account the time delay bias. And here, when you take into account the time delay bias, this is an adjuvant trial that I was the PI of. This was the Checkmate 238 trial in melanoma. This was a stage 3-4 resected trial. And if you look at the relapse-free survival, which was the endpoint of this adjuvant trial, in patients who either had or did not have either any treatment-related adverse event on the left or an immune-related adverse event on the right, no association of relapse-free survival with having toxicity. So the bottom line for me is it's a very weak association, and don't let patients get too worried about it. Tell them the patients who have no side effects may do very well indeed. What are the problems that we deal with? The symptoms of these immune-related adverse events can wax and wane. You can even have multiple irAEs in the same patient. You can have hepatitis, gets treated with steroids, gets better, and then they develop colitis. And again, don't wait too long to start infliximab in a patient with either cardiotoxicity or GI toxicity. 72 hours is the longest you should go before you need to make that decision. And again, if you have lingering grade 2 toxicity, it's okay to use steroids. And I would give a intermediate range taper, maybe 21 days. If someone has lingering amylase and lipase, which just doesn't go away in spite of steroids, I've had some success using mycophenolic acid. And if someone has really bad colitis, don't wait too long before giving them complete bowel rest. And the only way to truly put the bowel to rest is to put them on total parenteral nutrition, or as we call it in the States, TPN. Again, do we have biomarkers? Unfortunately, not really. The only good biomarkers that are associated with development of these irAEs, the only biomarkers related to the irAEs are if you develop vitiligo, then those patients may actually do very, very well. We do know that with nivolumab and pembrolizumab, there's a weak association with outcome. But are there any lab-based biomarkers? If you look at the bottom bullet point, I did a recent PubMed search. There are virtually no biomarkers in the literature that reliably are associated with the development of immune-related adverse events. We're working on it, but we just don't know. Lastly, can you continue PD-1 blockade after irAEs with, say, combination immunotherapy? Yeah, you can, but you're going to have a higher rate. This was a study that was recently published in the Annals of Oncology. And again, interestingly, colitis was a little less likely to recur, but again, you will have a significant rate of toxicity. Let's say patients who are on steroids, you're bringing the steroids down and you decide to continue therapy. If you look at the bullet point one up from the bottom, half of those patients are going to have recurring immune-related adverse events. And again, you can do very well. You will have an increased rate of recurrence, but about 20% of patients, after you have, say, a grade 2, 3, 4 adverse event, if they resolve and then you continue treating them, about 20% of them are going to have a return of the same or another immune-related adverse event. And again, here's another study that was done in Europe, published in JAMA Oncology. It was 40 patients who were re-challenged. And again, you couldn't distinguish who was going to develop a recurrent immune-related adverse event. The ones who did and the ones who didn't, every prognostic factor was the same, but about half of the patients redeveloped an immune-related adverse event. So the answer is yes, if someone has an adverse event, you treat it with steroids, it resolves, the steroid taper is ended, you will be able to retreat them, but they need to know that they have anywhere between a 30 and a 50% chance of redeveloping a same or even a different adverse event. I've been asked a lot about the use of tocilizumab to treat immune-related adverse events. That's an IL-6 blocking antibody, completely different than what we usually use to treat these adverse events. And here's a very interesting study which shows that you can actually use, especially in patients who fail other therapies, you can attempt to block IL-6 by using tocilizumab, and you can treat pneumonitis, serum sickness, or inflammation, encephalitis, or cerebritis. And this is what happens is you bring down the CRP, which happens with tocilizumab. That's what always happens. And actually, you can see most of the patients clinically improve and resolve, even if they've been steroid refractory. So the use of tocilizumab is yet one more element in the armamentarium. If they fail steroids, they fail Remicade or infliximab, you can think about using tocilizumab, the IL-6 blocking antibody. And lastly, the urban legend is don't ever vaccinate someone who's getting PD-1 antibodies. And I always thought that made no sense. And this is now a study where in a modest number of patients who had lung cancer, actually 42 of them got an influenza vaccine and 80 some odd of them did not. And there's no real difference in the incidence of any toxicity, side effects, any particular problems in those who got vaccinated versus those who don't. So if someone is due for a pneumovax or a flu vaccine, I tell them, yes, you're getting PD-1 antibody, just get your vaccine in between your doses. There's no reason to be overly worried about patients who are getting a PD-1 antibody getting vaccinated. I think it is just an urban legend that makes no sense. So, conclusions, take-home points. Most of these immune-related adverse events occur during the first 12 weeks. We think of this as the induction therapy. And again, steroids will fix almost every immune-related adverse event. The things it doesn't fix is type 1 diabetes and endocrinopathies. The symptoms will go away with replacement hormones or insulin, but once you inflame and toast the pituitary, it's gone. It's probably not going to come back. You need prolonged steroid tapers. Don't relearn the lesson that I had in 2001 when the first time I saw a patient with an irAE of grade 3, I gave him 10 days of steroids. Well, guess what happened? The colitis came roaring back by day 8. Okay, you need to give 30 to 45 days of steroids for pneumonitis, cardiomyopathies, colitis, or neurologic toxicities. Late immune-related adverse events can occur. I've actually seen this at almost 4 years of therapy in a very prolonged study. Multiple irAEs can occur, but other than the endocrinopathies, there's minimal evidence of any permanent symptoms, of any permanent side effects. Keep in mind, in spite of all the things I've told you, these drugs are safe, and with practice and experience, they are both easy to give and safe to give. And I thank you for your attention.